live, Bath County. We're with Secretary of Health and Human Services, Dr. Bill Hazel. Great to have you with us, Dr. Secretary.
Thank you, John. Good morning, and TGIF to you, too.
I know we love TGIF. Now, both of us were saying that we love being in Bath County and Hot Springs, but boy, that drive home on a Friday through I-64 and 81 and everything else, long drive.
Long drive indeed, but we'll get back to the Holy Anointed City before the day is up.
That's right, the Holy Anointed City. Well, Dr. Secretary, I was so excited to have you on today. You've worked in this position as a cabinet secretary in 2 administrations now in Virginia, so that makes you the ultimate nonpartisan, right?
Well, perhaps so, but what I look at is it's almost 6 years, so 7 years per human year is a dog year. So I figure I've been here 42 dog years, and that's Moses was only in the wilderness for 40 years.
So you're already ahead of that.
Something like that.
Right. So now, we were at dinner last night, and somebody brought something up that I was thinking about when I went to bed last night, and I'm like, I've got to ask this to Dr. Hazel, Dr. Secretary. And they were saying that you had been saying that the heroin addiction in the United States, which has gone up dramatically recently,
indeed.
You were saying that that people can get heroin cheaper than regular pain-killing prescription drugs. Is that true?
It seems to be true. Over the years, what we saw for a long time is an increased number of prescribed opiates, the OxyContins, the Percocets, and so forth. And as we have done a better job of reducing the number of pills out, and there's still a lot of them, there's still too many, but as we've reduced that, it's become a little harder in some places to get the pills. And the entrepreneurial heroin trade has found remarkable ways to deliver to your doorstep very high-quality heroin for the cost of a six-pack to get your daily fix, whereas the law enforcement friends tell me it's about $1 a milligram for OxyContin, so you're looking at perhaps $60-$70 for your OxyContins.
How is it getting in, and why is it so cheap? Heroin.
Well, I think the reading about it suggests that the ways that or the supply routes have changed, and we know let me refer you to a book called Dreamland. It's written by a fellow named Sam Quinones from the Los Angeles Times, who started tracking Mexican gangs, and he in his book talks about 2 phenomena. One, the medical industry prescribing and over-prescribing opiates, and then the other is the ability of the markets, the heroin providers, to bring the stuff in over the borders and get it distributed. In fact, there are even places in the country where you call a number and they'll deliver.
They'll deliver it?
Yeah. Now, you can't see John's face on radio, but yeah, you can get delivery. It's sort of the Domino's model for delivering heroin.
How is this possible?
I think that the bad guys typically stay a step ahead of the good guys. That's why we always chase bad guys. And
Doc, how prevalent is this in Virginia?
Well, what we've seen now is an increase in the number of deaths from overdoses, and that has been increasing for a number of years. I think we're finally realizing that we are seeing a lot of it. In fact, we have more overdose deaths in Virginia now than we do deaths from motor vehicle accidents. And so that would be, I think, just the tip of the iceberg. And when you go into different areas of the Commonwealth, you're seeing a different phenomenon, probably in the Northern Valley, the Winchester area, perhaps coming in from Baltimore or perhaps Philadelphia. You've got the Fairfax, Northern Virginia area is a different problem. In Southwest Virginia, it's more prescription pills and overprescribing and so forth.
I mean, that's just unbelievable. And those of us that aren't aware of this, that are out of the so-called drug loop, you think of heroin as, well, that was like a drug back in the 60s or something, and nobody does that anymore. But it's kind of amazing what you just said. We're with Go ahead.
Just want to say there are things that really seem to work. And before we leave the topic, I think it's really important that the communities rally around changing the culture that makes it easy to get these prescription drugs that start the habits. And we've seen in areas such as Winchester around Valley Health where the system has worked with the local prosecutors, law enforcement, and the courts to try to help solve the problem and reduce not only the harm but the addiction. Once people have the addiction, they have the disease, it changes the brain. So there is need for treatment.
Right.
There is need for prevention. The peer community plays a huge role in this. And then we have to continue the interdiction. We got to help law enforcement chase the bad guys.
Got to get those bad guys out, no question. One of the focuses that we've been talking about on our show for some time have to do with the fact that Virginia hospitals, especially those in non-density areas, are not getting the funding they need to survive. We've already had one hospital close in Southwest Virginia. Others are shutting services down. There seems to be no end in sight, no revenue model that makes any sense. Medicaid expansion, as you know, it just isn't going to happen in Virginia. What can we do? What's the answer?
Well, first of all, yes, there are a lot of hospitals that are having trouble. When you go out to rural areas, you have so many people who have no ability to pay. And then you have a large number of people who are either through the Medicare or Medicaid programs, perhaps not getting paid cost. And we know at least of 17 hospitals right now that are in negative operating margins. That means they're living on their reserves, which means they're living on fumes, and that's not sustainable.
It's not sustainable.
And these are large employers for the community. Now, as we look at healthcare, people have to remember, I think it was the ultimate liberal Ronald Reagan who signed the EMTALA law, the Emergency Medical Treatment and Active Labor Act, which basically says if you show up at the hospital, we have to take care of you.
That was signed on Reagan?
Yeah, it was signed under Reagan. Yeah.
So what happened prior to that?
Well, the story that set all this in motion, I understand, was this lady showed up at a hospital in Texas to deliver a baby, and they turned her away. And when you deliver your baby on the side of the road, bad things happen. And that was the story that I was taught. I can't verify the accuracy, but it sounds right. And people said, no, we're not going to do this anymore. This is America. So what did Congress do? What Congress does, they had an unfunded mandate. Now, health system, you get to take care of this. And if you think there's such a...
So it's actually it's actually a law.
Yeah, it's a law. It's a law. When they show up, we are obligated to assess and stabilize them, and that means they get into the system. And the challenge you get is that these folks who are uninsured typically come in later in the course of their diseases, maybe even with preventable problems. So we now are mandated to see people when they're at their sickest and most expensive and most likely to have a poor outcome. Now, the logical thing would be to try to find some way to help them earlier in their course of treatment. For instance, we won't pay for preventive medicine, but we will pay to put you in the hospital when it's done, and that's showing through our system. It's not just hospitals, but there are physicians who have to take care of these folks and so forth, and it's not logical. We can't solve the cost spiral in healthcare with the system that only guarantees the access at the end of the line, which is why I think we need to think of some sort of earlier way to provide people access with coverage. The ideal thing is, in the terms of the money follows the person language, is some type of an insurance package that does prevention.
So what would you be in favor, like if the leaders of the General Assembly got together with you and they all sat in your office and they said, okay, Dr. Secretary, we know we have to solve this problem. We also know what the political ramifications are one way and the other, and there's a lot of Medicaid expansion. We're just not going to expand Obamacare. What is and I ask this question to everybody that comes on, what is a solution that everybody could live with to solve this dilemma? In your judgment, Dr. Secretary.
People have concerns about the Medicaid expansion for a number of reasons, so we would try to address all of them. I do think that you need a basic package of benefits that get to people earlier. where they are able to get preventive care, primary care. The Virginia VCU has a model called the VCC program, which they set up for their uninsured population, which has been written up nationally. It's reduced the cost of taking care of these people 55%. So we have to get a program that insures early and brings them in and actually has outreach associated with it. Many of the problems that we are paying for in the 18% of our GDP that we spend for healthcare are not really medical problems, and we have to be able to have some flexibility to address those. So we would create a product like that would allow us, when need be, to actually take care of the trailer if that's the cause. Allergies that's causing you to come to the emergency room 7 times in a month. And stuff like this does work and lower the cost, so we have to have that piece. Now, the challenge with the, quote, all-volunteer system, I've heard you mention the health wagon before. I love
the health wagon.
Teresa Gardner's.
The mobile health wagon.
St. Teresa out here in Wise. I've been there. I've worked with them. But the problem with you just relying on a volunteer system is that healthcare actually, beyond what you can do as a volunteer one-to-one, costs money. You got to buy medications. There are surgical devices. There are nurses and environmental staff at hospitals have to get paid.
Blood tests.
So the idea that we can do this just voluntarily doesn't actually hold much water. So I would look towards a modification of the current essential benefit package that we have, the one that most people in Virginia get, and there would be, I think, some cost sharing associated with it that would be appropriate to income, but we would want one that doesn't lock people in to a program. And one of the interesting things that we can see in human services now that I think we have to address is that every time as you're trying to get to self-sufficiency, every step we make people make bad decisions. Do I take this extra income, lose my benefit? And you can do that a number of times. So we need to smooth that, and having that health care piece in it is really important.
Well, look, there's no doubt it is, and the preventative care is a big deal. It's real, and whenever someone goes to an emergency room for indigent care, if you will, I've heard that's 3 times what it would be if they were under a normal preventative care situation as far as the cost. So it just spirals out of control.
There are numbers out there. I can't say that it's exactly 3 times.
But it's higher.
But it's higher.
Right.
And the outcomes aren't as good.
Right.
And plus the other thing we have to think about is what we really want is healthy and productive Virginians. And we need people to be healthy, to stay in the workforce and so forth. So I think it's essential that we do get the coverage in place, and we also use this as an opportunity to improve the value for health care for all Virginians. When you talk about a sick tax, that's what we have today. When that person
a sick tax.
Yeah, well, we have it today.
Right.
It's just you don't see it. Nobody had to vote for it. That's the unfunded mandate. You show up in the emergency room, right? We take care of you. Who pays for that?
The hospital's paying for that.
Well, the people who have been patients in the hospital are paying for that,
because
right?
they have to charge them more.
That's right.
To pay for those that can't pay.
We are irrationally,
which they have to take by law.
Right. We are irrationally charging the sick, adding to our health care costs by having a totally unmanaged.
The whole thing makes no sense.
Yeah. So getting up earlier in, getting preventive care doing, looking at population health as a place. I think there are some issues around poverty that have to be addressed that increase costs. But when the next most expensive country in the world is spending 11.5% of their gross domestic product on health care, and we spend 18%, even an orthopedist knows that's 6.5% of GDP, and the entire U.S. defense spend is only 3.5%. We can't. They cover everybody. We don't. That's part of the problem.
And our percentage of healthcare to GDP is higher. Right?
Oh, our healthcare spending is much higher. When I go out to speak at VACO and I say Switzerland a couple of years ago was second, spending 11.5% of GDP, I asked the supervisors, any of you all lost a job to Switzerland recently? They look at me like I'm crazy, which may be accurate, but the fact is that those are costs that we bear as a country as we look at employment and we look at substituting health care for wages, and people need other things. So we've got to continue to work to fix the system, but you can't fix it unless we're starting with a common platform of coverage.
makes a lot of sense. We want to thank Secretary, Virginia Cabinet Secretary of Health and Human Services, Dr. Bill Hazel, for being with us. He's been our